It's so interesting in working through this process from a hospital perspective, because for us on the hospital side, we haven't been dealing with this issue as long as public health has. So we do come at it with a little different viewpoint, and we'd like to spend a few minutes just talking about the real-life case study that we're working through right now. It doesn't mean that we have all the answers. It means that we're simply working through the process. It is a partnership with Ashland County Health and Human Services, Bayfield County Health Department, and Memorial Medical Center. As Julie mentioned, it is two very different health departments structured very differently, and Memorial Medical Center, which is my facility, which is a critical access hospital in northern Wisconsin. I think a frame of reference is always really important for everybody to understand, and those of you about 10 years ago who used to look at that New York perspective of the United States, where New York is there and everybody else is over there, well, for us, this is the map of the world as we see it. And here's where we are. And now you understand why the data that we were collecting had to do with the number of milk cows per people in northern Wisconsin. Cindy, do you want to talk a little bit about this?
So Ashland and Bayfield County are in the northern part of Wisconsin. To give you an idea of Ashland and Bayfield County, the whole northern half of Wisconsin, population-wise, is less than Milwaukee County. So a lot of land, not a lot of people. But we neighbor, we share Lake Superior, and we share a lot of other resources. Ashland County, Bayfield County, both very small in population, just like I said. Native American is the highest minority population in both counties. Both very poor counties, and both do very poorly in the state health rankings. And we attribute a lot of that to economics because we are so poor. Memorial Medical Center is the only hospital in both counties and neighboring Iron County also. It is a critical access hospital status. You can see the revenue from it. And it's one of the 3 largest employers in both counties. So we were familiar with it. This is not the first time that the 2 counties and the hospital have collaborated together. We actually have a pretty strong history of working together. We have an influenza coalition, the SIC, the Superior Influenza Coalition, that we work together with to try to make certain that we have enough influenza vaccine to cover the whole counties. We've worked very well together on emergency preparedness. Of course, we work on a network of public health, of health issues. I told Kevin, they get the people sick with communicable disease, and then we follow up, try to find out why. So that's how we work well together. And then we do well with public relations network. We have one paper that serves both counties, and boy, it really is rural, isn't it? And so we run a Health Matters once a month, and we collaborate together on running news media for that. As Julie said, this is a state mandate for health departments to do a community health assessment. Has been for 20 years. This is the 3rd time around for Ashland and Bayfield County to work on it together. This was Memorial Medical Center's first time to do it. And I can't tell y'all how glad we were to see them come on board, because they had the money and we didn't. So. And by the way, everybody there talks like me. this button.
She's from southern Ashland County.
Nobody talks like her. Julie showed us this wheel. And this is what we looked at when we first started getting together with our hospital partners. And we actually used it as an outline with dates of how we would move through our progress as we put this planning into place. One notation that I want to make on this is that what you heard Cindy say, our counties are large geographically and small with population. Memorial Medical Center sits in Ashland County. In my county, we do not have a hospital. We, by nature of geography and partnerships, have a long-standing history of partnering with our hospital, as Cindy outlined with some of the activities that we partner on. So well before this June date, when we started this process, we had been having conversations, and I want to say, I think it was almost 2 years before that, when we started hearing about the changes that hospitals were going to have with having to do a community health assessment and develop a plan. We were already at the table talking and planning before we even got to this. Because truly, in those areas, we're talking almost all the time. We're partnering in many layers. So this was just a natural layer for us. We used this wheel, and actually Kevin did presentations with department head staff within the hospital. Many of us use this within our board structures to give them an idea of what process we were going to be using and what timelines we were going to be working on. And then to tag back with what Julie said, in Wisconsin we call it chip with 2 Ps. This is a continual process for us. So basically, the wheel doesn't stop turning for us. Our steps was, as always, we begin with assessment. We reviewed the previous plans that we had. The hospital was not a full-fledged partner at that time, but they had been at the table for every plan that we have written. They've been there with us. They've sat on the work groups. They were in the strategy planning. But what we did is we pulled out those old plans. We looked at what goals and priority areas had been set, and we looked at what had been done in the community and measuring the bar of if we'd moved anything or if we'd had any impact with the activities that we'd been doing. We sat with the hospital and planned out, how are we going to do this next assessment? What are we going to look at? What's the process we're going to use? We did come up with community listening sessions. Now, as you saw the large maps, we've got a lot of geography to cover, especially when we're combining 2 counties. And some of our municipalities, I would have to say, both of our counties are more than 56 miles long. So we targeted a lot of the municipalities because one of the focuses that we wanted was to outreach to people who were not within the city where the hospital sat. We wanted to really give people a voice into this listening session. So we set up a lot of them, and we did a lot of evening drives, and we sat with people and invited them in to come in and have those conversations with us. We developed a survey tool of primary questions, and for this, because the health departments and the hospitals, sometimes not the hospital, but the health department specifically, struggle with finding those additional people and resources. We used students. We used interns, and we used students during summer months, and we actually used what we call AHAC students, Area Health Education. Okay, great resource, come with tons of energy. We had those folks canvass our communities and use hard copies because some people were very receptive to doing hard copy surveys, but also developed an online, which we got great responses from. I mean, truly great. We had a student set a target number of 500, and maybe for your communities that's not a lot, but when you're talking about a 30,000 population between the 2 of us, we got 500 done online. So that was a great tool. We surveyed, and then when we had those initial data pieces, we started analyzing where we stood with the information that we got based on national, state, regional, and local data. And when you deal with public health departments, you hear a lot about data because we're data people. For us, data was a little bit more difficult and it's a little drier, but we wanted to marry what people in our communities were telling us were the problems versus what the data supported was the problems. And if I put my public health hat on, we're supposed to understand what's going on in our community and what the needs are in a community. And I will tell you, as we went through this process, I had put some things out there what I thought it was. But once we talked to people, it wasn't what I thought it would be. From that assessment process, we ended up with a prioritizing session. We held a stakeholders meeting, and from 2 different counties, we pulled together what you guys would call the movers and the shakers, the people who represented schools, businesses, different population groups and committees, pulled them all together, held a very large one-day event where we presented all of this assessment data and process that we'd been through, and then had dialogue, did gap analysis, had conversations, and did some presentations of Healthy Wisconsin 2020, listing out what the priority areas were in that. From that, we began to plan. We reviewed all of the data that we had collected. Sure. Day-long meeting. You know, you know, and I thank you for asking that, because in the past, we had not done it that way. In the past, we had looked at what some of the priority areas were that we thought, and we'd pull together people who represented those kind of groups, and we had work group meetings, and sometimes we'd do it 4 hours, 3 times, you know, and pull together. This was a process we'd seen several other health department or planning processes use, a one-day. And the carrot was, we selected a neutral site, which was a very, very nice facility, and the hospital helped with funding. We offered great food. I mean, food is the carrot. It was great food. It was a great luncheon. The invitation was very open and inviting, and it had wording of, tell us what you think. You know, help us put this together. And I think that helped. But you're right, it is hard to get that many people representing that many entities around the table for one day. But I think that's part of the process to say, instead of asking you to come multiple times, we're going to ask you to come once.
Can I just add one thing? You mind?
Not at all.
After our one-day session, we all three came to the conclusion that we would never do a one whole day session.
Yep.
We would do 2 half days.
Yeah.
Because one whole day was a long day.
Yep. And we started that day with a data presentation, which was a very in-depth data presentation on all of these different areas and how we compared again nationally and statewide and with our region. And I believe it was 3 hours long. Yeah. Well, we lost a few people by lunch. So when it came to the afternoon where we started asking these groups of people that what they represent, what do we got in these areas that's working? And where are the gaps? Because that's truly the information we needed from them. You know, no one could give it to us better than those people really working in it. And I feel that people were fatigued by that time. So maybe not a best practice, and we did say.
And I would say, Terry, if you're looking at the concept of adult learners, the best practice is not a full day.
Yep.
And so then it's the trade-off between you get everybody in the room and you lock the doors and you keep them there until you're done.
Yep.
Or you get different people on day 2
Yeah.
so that you're not building from day 1 to day 2. So
Yeah.
there's a trade-off there. And I think that we're willing to say we take the trade-off of doing an afternoon, have
Yeah.
people come back and do a morning and finalize it. That would be better, especially if you look at evidence-based practice of adult learners.
Yep. And, you know, trying to get people from schools and from those type of things there more than once, it's hard. I mean, people are busy and people are committed. But that is the process we used, is the one-day, all-day event. We did a ranking analysis, so when people finished that whole day event, they handed in to us on paper their top 3, what they felt based on what they'd heard that day and what all the discussion points were, their top 3 areas. Again, our steering committee met. We had discussion on that. And this plan, and this is the unique piece that I want to put out to you, our hospital said to us, as the 2 county health departments involved, you public health people always pick so many priority areas. You pick 3, you pick 5. We're not seeing, you know, that how do you have the energy and how do you move the bar? Is he making faces at me? I'm gonna turn my back to him. This is new for us because this year we said we're gonna pick one. We're gonna pick one thing that we're gonna throw every bit of energy we have between 2 counties and all the partners in our hospital and see if we can actually move the bar. So we're at the point now where we're building that implementation plan. Our plan is pretty much written and ready to send out. We've been doing presentations to our community members, hospital boards, county boards. And like I said, this is going to be an ongoing process that we're going to evaluate and then reassess and move forward. So for Ashland and Bayfield County, this has been our #1 issue, and my public health hat would not have said that this was it. They know that when I went into it. It's not going to be that. It's going to be nutrition and physical activity. It was, and this was so far and above everything else that came out in our strategy, alcohol and other drug. This is a frightening one for us because this is huge to move the bar on this. But I will tell you that of the 72 counties in Wisconsin, many of them have this as one of their priorities. So, based on template, and Julie, it doesn't look exactly like yours, but this is our guide of how we're moving it through. And I'm not, because you have this in your slide, I won't read through the whole thing. But we did set our goal, and our goal is a very broad spectrum goal. The performance measures using the same language that Julie put out there, short-term and long-term goals. And a lot of this is going to be tied into what we heard from our keynote as far as how do we create synergy? How do we get all the different people who are working in these areas together to start driving for change? Because truly, in an area like this, it is the only way we're going to create change. So we have to ask, what's the ask when you bring people? What can I do to impact the AODA issues in Ashland and Bayfield County? And what we're looking for, and the key is collaboration, to start to get these people who sometimes are protective of the work they do and what they do, together to start driving this bus to see improvement. Again, we're using some of these implementation tools that guide us on when people say, what is the ask? What can individuals and families do? What can organizations and institutions do to have impact in our community? And this helps us start those elevator speeches or that language. And what can communities and systems do to help create impact? Again, tied back to a lot of what we heard in the keynote speech of it takes many different partners to deal with extremely complex issues.
So when we came together, we were all willing to work together. We knew, Terry and I both knew that we had to do it as a state mandate. And then Kevin came to us and he knew he had to do it to report to the IRS. And like I said, we were really glad to see him come on board for us because in Wisconsin, this is an unfunded state mandate for local public health departments. We knew that we wanted to make a difference. We decided from the very beginning that we were not interested on a pretty document that we could put on a shelf. We really wanted to make a difference in our communities. We all felt very strongly about the people in our communities because we all live there and we work with all of them. And we knew that this time we wanted to make a difference. We all have a good understanding of our people in our communities. Like I said, we all live in those communities. We work in those communities. We know the people. Those are our families. Those are our neighbors. We had a good understanding of where they were, and they were very open with us when we did our community listening sessions. In fact, I have to tell you, when we had our stakeholders meeting, we did a video, ran a short video of some of our listening sessions that we had on. And it was very moving to the people, and it actually had a lot to do with the focus area that we chose. We were willing to listen and to compromise with one another. Just like Terry said, she really wanted 3 focus areas. And Kevin really wanted only 1. And I only wanted 1 because I just didn't want to work on 3. So we were willing to listen and compromise. We had a shared pot of resources because of all of us being from the same counties. We shared the same partners in terms of the care providers. We shared the same resources in terms of the community partners that were working with us. We had some not so common ground. Our reporting structures were different. Terry and I were reporting to our local boards of health. We were reporting to the state and in turn reporting to the federal government. Kevin was reporting to his board for the hospital, but he was also reporting to the IRS, so that really made it nice for Terry and I. Our funding options were different. Quite frankly, Terry and I had no funding, and Kevin had a lot of funding. So that made it different for us.
IRS.
He had, what should I say? He had a more steady funding than Terry and I had. That's probably what I should say. We had a different organizational structure. Terry and I were coming from local government, and he was coming from a not-for-profit acute care hospital setting. And then the lens of public health was different than the lens of the acute care hospital. He was interested in treating people when they were sick and injured, and Terry and I were interested in preventing those injuries and illness. And his focus was individual people coming into that acute care setting, and Terry and I were interested in the whole population at large.
So in talking about this, I think that there are some lessons learned for us, and we're continuing to learn lessons. I think a great way for your steering committee to get to know each other is send us all to St. Louis for 3 days, and we're able to talk over breakfast, lunch, and dinner, because we found some very much common ground in these last couple days that we've been together in talking about how we're moving forward. And I think that that's one of the key lessons that we learned, is this is a process. It's not about the end result. It's not about the publishing of the report that's most important here. It's about understanding who we are, who our agencies are, and who we're representing in our populations. It is the process that takes time and energy to know that although we look at things very differently from public health and acute care hospital sides, there are things that we can do if we talk about it and work together on it. And that's one of these process pieces that I think is important for the lessons learned for us. We also know that if you have people who are going to stay at the table long term, they're vested partners long term in what you're doing, it makes a huge, huge difference for your end product. There were many times when we would be sitting at the table and we knew we were disagreeing or we weren't talking common language, and we stayed at the table to make sure that we worked through that because it was an important thing to do for the right reasons. So vested partnership is really important in this process. Terry mentioned that she kind of knew exactly what the plan was going to look like long before we went and got information from our stakeholders and before we even canvassed our communities. And I think an important process here is to really open the floodgates and let your public speak to you about what they see as important. Don't go in with preconceived ideas, because you will get exactly what you perceive is going to be the outcome, and it may not be right. I don't think any of us would have picked alcohol and drug as the #1 issue for us. But by opening up the floodgates and really looking at the importance of collecting data, we were able to come to that conclusion. So opening up the floodgates for data is really, really important. The other thing that really bridged the gap for us is the consistency of the tools. And I can't tell you how valuable those tools have been. The guidebook that's available to you online, the information that is at chna.org is an incredibly valuable website for you to be looking at. That bridges the gap for us to be able to talk the same language, but also to look at how are we going to move along in this process in a consistent, straightforward kind of way. It gave us the common ground that we needed, even though there were the differences that Cindy talked about a few minutes ago. We also have found that this process has been a really valuable process, not only for the CHIP, but also for loads of other things that we're doing on an ongoing kind of basis. We are much quicker to pick up the phone and call public health than we were before this process started. We understand their expertise, we understand who they are, we understand how they operate, and most importantly, I think we really understand the important work that they're doing every single day for the same people that we are looking to serve well. I think in this whole process, we have found that we have really bridged an understanding from two very different points of view, and it's not changing the point of view. It's keeping the 2 points of view and bridging the gap between them that has been so important for us.